CAD/CAM restorations is a versatile process. From the most crucial factors are the fracture resistance and marginal adaptation. It's possible to predict the fracture resistance of a substance from the strength of individual bonds between the atoms in the material. The values of strength obtained by such a prediction are typically 10% of modulus of elasticity. Of sure, a large increase in fracture toughness occurred when the elastic modulus of substrate increased. The elastic modulus, Young's modulus, represents the slope of the elastic portion of the stress-strain curve. It is the relative stiffness of the material within elastic range. The stronger the basic attraction forces, the greater are the values of the elastic modulus, and the weaker the forces, the lower is the value, and the less rigid the material. Evolution of dental CAD/CAM tools is industry-driven. CAD/CAM has been around for a long time. It has been used in industrial manufacturing for many years, creating everything from tiny parts such as bolts to very large parts such as aircraft wings. Medical devices are designed using CAD/CAM programs. The materials of CAD/CAM blocks may be ceramics or resin material and metal. The ceramic revolution started from the beginning with feldspathic porcelain, then zirconium, and finally with hybrid ceramics. More than 20 systems today are competing in the market. They are all different in implementation and capabilities. They may be classified as follows according to ISCO: those that produce a full arch restoration versus those that are limited to framework only. 2, those that produce few units versus those that produce full arch restorations. 3, those for which the digital impression is taken intraorally versus those in which plaster dies and models are scanned. 4, those in which the fabrication unit is in the dental office versus those in which the electronic files are transferred to the larger lab for fabrication. The recent classification of dental ceramics by McLaren states that 1, glass-based systems, feldspathic; 2, glass-based systems with crystalline phase and fillers, as Emax; and 3, interpenetrating phase ceramic, as in Ceram Vita Enamic; 4, polycrystalline solids, alumina and zirconia-based polycrystalline ceramics. The glass-based systems are made from materials that contains mainly silicon dioxide with various amounts of alumina and natural occurring aluminosilicates. Their mechanical properties are low, with flexure strength usually from 60 to 70 megapascal. Thus, they tend to be employed as only veneer materials for metal or for ceramic substructure, as well as for veneers. 2, the glass-based systems with crystalline second phase range from moderate to low lucid containing feldspathic glass as spheric blocks to high lucid containing glass as glass ceramics, Empress CAD, and 3, lithium disilicate glass ceramic as Emax CAD. Interpenetrating phase ceramic as alumina in Ceram and in Ceram zirconia. The in Ceram alumina has high strength and moderate translucency and is used for anterior and posterior crowns. Zirconia is used mainly for posterior teeth because of its very high strength and lower translucency, and is used primarily for 3-unit posterior bridge. The flexure strengths range from 450 megapascal to 650 megapascal. Lava Ultimate Restorative is a resin nano-ceramic. It has elastic modulus that's comparable to nictine, which is much lower than brittle glass ceramic materials or porcelain fused to metal veneered porcelain. It enables lava to absorb showing forces and reduce stress to the CAD/CAM restoration. Vita Enamic is a hybrid ceramic comprised of a structure-centered ceramic matrix, the pores of which are filled with polymer matrix material. The mass percentage of inorganic parts is 86%, while the mass percentage of organic polymer is 14%. The nanoparticle size are below that of visible light, from 400 to 800 nanometers, producing highly translucent materials, improve wear resistance, gloss, low modulus and flexure strength, tensile strength, and fracture toughness. Nano-ceramic particles are embedded in a highly cross-linked resin matrix, 80% with nano-ceramic and 20% with resins. Their indications are crowns, inlays, onlays, and veneers. As I mentioned before, lava ultimate resin has a low modulus of elasticity. It can be used with porcelain fused to metal. It allows for absorption of showing force and can be used over implants to decrease the stresses over them. Vita Superinity is a new generation of glass ceramic products with the aid of innovating manufacturing process. The glass ceramic is enriched with zirconium, approximately 10% by weight, and the results are the world's first zirconia lithium silicate ceramic and aesthetic restoration. Polycrystalline solids are alumina and stabilized zirconia-based polycrystalline ceramics. The crystals of zirconia prevent crack propagation through the restoration, as shown by the figure. After that, 3M introduced three types of blocks, recent blocks: paradigm C block, lucid glass ceramic, and paradigm MZ100 block composite, and lava crowns and bridges. Lava zirconia is indicated for posterior, and composite and lucid glass for anterior restorations. The correlations between the blocks and superstructure material and design. For full contour restoration, we have glass and crystal, Vita blocks Mark II, glass and lucid Empress CAD and Paradigm C, lithium disilicate as Emax CAD, hybrid restoration as Enamic and Superinity, and finally zirconia. The framework may be metal or zirconia, metal as in coarse C, and zirconia as lava. The temporary restoration as Vita CAD 10 and Paradigm Z100. The abutment over implants may be Emax abutment or in chorus YZ mesoblock and TilioCAD abutment. The presence of marginal discrepancy exposes the dental hugening agent to oral fluids, foods, bacteria, thereby leading to periodontal disease and secondary caries. For CAD/CAM generated restorations, approximate acceptable marginal gap discrepancies are less than 90 micron. The marginal gap measurement has been defined as vertical and horizontal marginal discrepancy over and under extended margin, seating, and absolute marginal discrepancy. Today, there is no standard method available for measuring the marginal fit. The most common method is to measure the distance under a microscope after sectioning the embedded specimens. This discrepancy depends on the fabrication stage, the type of capping system, the number of units in substructure, the location of tooth, the tooth preparation design, the material stiffness and the type and thickness of the cement used. In CAD/CAM system, it's possible to program the software so additional space can be provided to accommodate for the cement, potentially influencing the internal and marginal fit values. In these experiments, 20 extracted human maxillary first molar with no defects were used in the study. The average buccopalatal and mesiodistal weights were adjusted 9.71 and 9.30 millimeter. Roots were embedded parallel to the long axis of teeth into self-cure acrylic resin up to 2 millimeter below cemento-enamel junction using plastic rings. The teeth were randomly allocated into two groups. For each tooth, an impression was made with polyvinyl heavy body siloxane impression material, which was sectioned and used as an anatomical guide during tooth reduction. All samples were prepared to receive all ceramic restoration. The dimensions of preparations were performed as follows: occlusal reduction 2 millimeter, 6 degree convergence, axial 1 to 1.5, and the finish line located 0.5 millimeter above cement enamel junction. And all finish lines are performed with 1 millimeter wide, 90 degree. Impressions of each tooth were made with a polyether impression, soft and medium. Master dies were fabricated with type 4 dental stone. After fabrication, all models were sent for production of coping and all ceramic restorations. The measure was done according to criteria proposed by Holmes. All specimens were slide 2 millimeter thickness in buccolingual direction. Measurements of marginal discrepancy were made at 5 equidistant points on 4 axial walls. And finally, crowns were cemented on prepared teeth using resin composite, Scotch Bond universal adhesive, and Re-X. Then all samples were thermocycled and stored at 37 degrees centigrade for 24 hours before the test. The specimens were mounted in a jig that allowed the loading with long axis of the root in a universal testing machine with Crotz head speed of 1 millimeter per minute. All crowns were loaded until catastrophic failure occurred, and the testing machine automatically recorded the fracture force in Newton. Fracture pattern was then evaluated by electron microscope. This table showing the marginal adaptation and fracture resistance. The marginal adaptation for resin nano-ceramic was 68 microns, and for zirconium 80 microns, much larger, and fracture resistance for resin nano-ceramic was 1,483, and for zirconium 1,952. And this graph showing the marginal adaptation of different restorations. This graph showing mean fracture resistance. This for resin nano-ceramic, much lower, significant, and zirconium. Discussion. Zirconium dioxide showed higher fracture resistance than resin nano-ceramic. This is due to the very high modulus of elasticity compared to resin nano-ceramic. The densely centered ETA tetragonal zirconia polycrystal prevent the crack propagation. And resin nano-ceramic restoration recorded better marginal fit because of the different composition. The improved edge quality may be attributed to the combination of the high strength and low modulus of elasticity to withstand the milling stresses without suffering the shipping damage that may occur to the restoration due to the cross-linked polymeric matrix. Within limitations of the study, the following conclusions can be drawn. One, zirconium dioxide restoration showed higher marginal discrepancy than resin nano-ceramic. Two, fracture resistance of zirconia is significantly higher than resin nano-ceramic. And all fracture values obtained in this study were superior to the assumed maximum mastication force. And both of zirconia and nano-ceramics demonstrated acceptable marginal discrepancy less than 120 micron and above 950 Newton. Resin nano-ceramic reduced laboratory and clinical steps and provide a practical solution combining the strength, fracture strength and low modulus for posterior restoration, especially over implants. Number 3, long-term follow-up studies are necessary to evaluate the clinical outcome of different CAD/CAM fabrication techniques. Thank you very much.